apologising. You've got a very polyglot programme here. You're moving quite rapidly, I think, from one thing to the next, and I hope you're keeping up with it all. I mean, I don't claim to be an expert in maternal mortality, but all I want to do really is very quickly give you the headlines, some of which you may already know, but then also to raise some questions. And obviously, if we had longer, and the programme's great because it's so packed, but also at some point it's good to unpack, maybe in more conversational settings, some of these issues. If we had longer, we could try and disentangle some of the things that I'm wanting to talk about now. And to an extent, they also follow on from the presentation that Lois McCullough gave, and also that Andrew Salmon gave earlier on today. And it links to the risk agenda, which is the agenda that Kathy's just been talking about. So even though the programme is very varied, there's some very interesting links between the content, I think. Okay, I don't think this will be too surprising to any of you. MDG 5 should all be in our veins by now, that we should reduce maternal mortality by 3/4 by 2015 and achieve universal access to reproductive health. That's the idea behind MDG 5. What do we know? Well, we know this, and this has not changed much. And you know, this really struck me when I actually suddenly realised there's about 600,000 women a year dying in pregnancy. There's about 600,000 women in the UK who get pregnant. So it's the same, or have babies in fact. So it's the same as every single woman who gives birth in the UK dying every single year. And when I first realised that, I thought, God, I knew it was bad, but can you imagine? It brings it home, that kind of analysis. And again, we all know this, low in the UK, high in Africa, particularly high in certain parts of Africa, Ethiopia. Actually, I think Afghanistan has currently got the highest rate for reasons that are fairly obvious. And 1 million young children, which again I worked out was something like half the babies born in Europe every year dying. So putting it in that kind of perspective makes you realise that these are phenomenal figures. And again, I don't think this will be a particular surprise to you what the key factors are. More than 80% have the 5 direct causes of unsafe abortion, severe bleeding, infection, eclampsia and obstructed labour. And again, not a surprise as to where the key areas of maternal mortality are. Largely in Africa, but also in India. And India is accounting for an increasing percentage of maternal mortalities, and that's something which has been kind of overlooked, I think, until quite recently. And I suspect Pakistan is now going to be steeply rising over the next year or so. But this, I think, is actually perhaps not so well known. When we look at the maternal mortality by country from the top to the bottom, interestingly, Italy, with the highest caesarean section rate in the world at the moment, has the lowest perinatal mortality, maternal mortality, which bears some thinking about. The UK is okay but not brilliant, but the US, 16.7, very high amongst all the countries of the developed world in the US, maternal mortality, which makes you wonder why our government is wanting to emulate the US in terms of the way that we deliver our healthcare. But that's another issue altogether. And I think I want to kind of put this in the mix, really, that it's quite easy to think, oh, it's Africa, and what can we do about it? Actually, it's not just Africa, and there are issues that we need to be starting to think about that cross over, I think, both the maternal mortality agenda and the risk agenda. And you may know that there's been debate about whether the rising rate of maternal mortality in Australia is actually because of privatised medicine that marginalises women who are already marginalised, and therefore you're getting an alleged increase in maternal mortality. In the US, they don't accept this. They say it's to do with the way the numbers are counted. But certainly internationally, that's seen as a fact. And it also links with the Northwick Park investigation, which again I suspect most of you will know about. Northwick Park Hospital in the UK, where the maternal mortality rate was significantly higher than in the rest of the country. And there was an investigation in there into why, and while the investigation was going on, they had another series of maternal deaths. And what they found was that basically systems and processes were not effective, which again you can understand. There was a lack of leadership, perhaps not surprising. But the thing that interested me the most, because I think these are some of the things that might cross over between various different countries, poor inter and interprofessional relationships between midwives and consultant obstetricians as a factor underpinning the high rate of maternal mortality. Now, as I say, we may think, what can we do about Africa? We can certainly do something about this. This is something we must do something about. There's a moral imperative that we do, it seems to me. And I want to talk a bit more about how that might work in other contexts as well as in the UK. Again, fairly well known, the three barriers. The ones that in blue are the ones that are usually quoted. So a barrier on when you seek care, a barrier on getting to care once you decided to get there, and a barrier on getting care once you get to the place that you need to go to. And this has been separately broken down into layers of factors, so socioeconomic, how accessible facilities are, and the quality of care when it's delivered. And again, this is generally cited in Lancet papers for countries like Africa and India, but some recent work we've done, particularly around access to antenatal care, suggests it's also true in the UK. Asylum seekers, for instance, fall into those boxes very easily. They don't seek care because they're afraid of being deported. They can't get to care because they don't know where it is very often, or they come from countries where they're not used to having antenatal care. It's not part of their mindset. And once they get there, they tend not to get adequate and appropriate treatment in some cases because they're seen as marginalised, or they're asked to pay. And actually, emergency maternity care should be free, whatever situation you're in. So these three barriers are not just about the poor developing countries, dismissively. What's the progress so far? Again, I think most of you will know, fairly dismal. This is actually quite an interesting quote from last year, that the current global financial situation is going to make matters worse, was the prediction, not better. Having said that, there was a recent paper in the Lancet, I think it was a Lancet this year, which is a light in the darkness. There are, in some countries, there do seem to be some improvements, particularly Brazil, the Philippines, those countries, there is improvement happening. So that paper in the Lancet, was the most recent one, was saying we're still not going to reach the Millennium Goal by any stretch of the imagination, but in certain countries the trajectory is increasing, they're beginning to get closer, so there is some light. What kinds of things might make a difference? Well, it seems like political and financial solutions are pretty important, well, they're extremely important. So countries where girls are educated and where microfinance systems are in operation so that the economics of the local community are being buffered, do seem to be delivering more positive outcomes for mothers and babies. So that's nothing to do with the maternity services, although in some countries they're actually enabling midwives to do things like run microfinance schemes. So one of the ways that they're financing their skilled midwifery workforce is to give them the capacity to run microfinance schemes, which brings income to the midwives, but also incentivises the community, begins to bring income into the community, and particularly to the women in the community. That's the important thing. The money goes through the female line, and it seems to make a difference by doing that. The clinical solutions are the ones that we probably tend to hear most about, certainly in research publications. And the main interventions are listed here for the main outcomes that are problematic. So oxytocin and manual compression for bleeding, iron supplements for malaria treatment, antiretrovirals, very important for indirect causes of death, use of the partogram, and I don't know if Tina's still here, but I think she's still here. Lavender's had an input into the partogram use at WHO level. Use of tetanus, toxoid, immunisation, clean delivery, because infection is extremely important, so antibiotics too. Family planning around the abortion issue particularly, and magnesium sulfate for eclampsia. I think what's also important here is that we tend to think about maternal mortality around the time of the intrapartum period. And there is obviously a big surge around the intrapartum period, but actually there's another surge around a week or so postnatal, which is infection. Which is caused by infection or the consequences of obstructed labour. And one of the big pushes now at the moment, and again Tina's been involved in this, is to improve postnatal care, which actually is ironic. At the time when we are dismantling our postnatal care in the UK, they're beginning to realise how important good quality postnatal care is to prevent maternal and particularly infant, because actually more babies die in that later period as well. So, maybe we could learn from the so-called developing countries as far as this is concerned. EMOC, emergency obstetric care. Again, you probably would have heard about this. There's a lot of emphasis on delivering EMOC to improve maternal mortality, and you can see that there are 6 basic functions, which are the ones over here. And then there's the addition of cesarean section and blood transfusion if the woman can be got to a facility. The others, antibiotics, oxytocins, anticonvulsants, manual removal, assisted vaginal delivery, removal of retained products are techniques that are supposed to be able to be carried out at local health centres. That's the idea. But I want to actually move on to organisational solutions, because I'm kind of interested in this, because again it has a great resonance with what's happening here in the UK. Skilled birth attendant. Now this was, again, this is a bit of a presentation on this by Lois earlier on today. There is a definition of a skilled birth attendant by WHO, highly contested. It's really not clear what is meant by a skilled birth attendant. Is it a midwife? Is it a doctor? Is it an ancillary worker with some extra training? There's also a big debate, there's been a big debate, and again that was mentioned earlier on from the audience, in a couple of lists, e-lists, a WHO list and actually more recently HIFA 2015 list, around the TBA and the skilled birth attendant, and very polarised views on whether it's a good or a bad thing from across the world, the TBA. The South Americans are incredibly interesting in this regard, because the South Americans differentiate between traditional birth attendants, who they say were often introduced young women pulled off the streets effectively by governments who want to increase their TBA coverage, who don't really want to do it, and again that came up a little bit in Lois's talk, and traditional midwives. Because what the South Americans say is traditional midwives, and again that came up in Lois's talk from Cambodia, have chosen to do, well it's slightly different from what you said, Lois, but have chosen to do the job, or they've done it because their parents did it, their mother did it, or their father did it, so it's gone through generations. And they've built up over generations and years of experience deep and profound skills in maternity care. And the question is here, who decides what is a skill? What's a skill in maternity care? Is it just that you know when to transfer and that you can do, take blood pressure or give drugs? Or is it about recognising when birth is normal and when it's not, about positioning, about massage, about all the kinds of things that traditional midwives over years and generations may have built up skills and knowledge in? Or is it both? Should we combine the two? And not just see a TBA as an inconvenience or a stopgap before we get to midwives, but to see them as our sisters, from whom we might learn and to whom we might give knowledge as well. And that's been a big debate. So who is actually providing care? Well, a whole range of people, as you can see. TBAs, dyers, traditional midwives, matrones, are the traditional Latin American midwives. And what is the evidence for this? What's the evidence base, in fact, for the feasibility of the skilled birth attendant? I mean, we make this statement that it's good to have, but we're not quite sure what the evidence base might be. And there actually is no formal evidence base for the introduction of skilled birth attendants by and of themselves. And obviously we know when systems improve and when you get more skilled people in place, maternal mortality goes down. But what components are actually at play there is quite hard to differentiate, to tease out. And we also know, and again that came up in Lois's talk, that skilled birth attendance is a distant reality. I mean, looking at the numbers that were trained, I can't remember exactly, but the RCOG ran a couple of days on this, and I'd worked out for that how many years it would take to train enough midwives that we need across the world. It was something like 30 years, massive amount of time. So we do need different kinds of strategies, because we can't rely on skilled birth attendants if by that we mean trained midwives, in the short term at least, and certainly not trained obstetricians. Just as an aside, it's interesting to look at the evidence base for alternatives, and this evidence is actually around physician aides, so people who are not doctors but work alongside doctors with some minimal training, sometimes more than minimal training. And actually the review by Davolo a few years ago showed that this was definitely a cost-effective alternative in some settings, and actually there wasn't much difference in outcomes when you used physician aides who were trained as opposed to doctors who've been through a traditional medical school training. So that's worth thinking about. In terms of TBAs, again, there's not much good evidence about the introduction of TBAs per se, but there is evidence about training TBAs. In a Cochrane review, and there were 4 studies, large numbers, and basically the one cluster RCT, which was the best quality one, did find lower rates of adverse outcomes in a number of areas when TBAs were trained, whatever training means. And again, that's another question, what training is. Does the evidence go just one way or both ways? Do the skills and wisdom go just one way from professionals to the TBAs, or does it go both ways? The recommendations from a recent paper a couple of years ago, I think now, from Una Campbell and her colleagues, was that basically there's only a few things you have to do to reduce maternal mortality, and the main thing, they said, was to prioritise delivery in primary level institutions. Now, since then, Una Campbell's had a think 4 years ago. I've been talking to her about this, and she is very concerned that although the evidence does suggest this, there is a risk that if you move women to low quality institutions where they get worse quality care because they've got badly trained staff who aren't paid, who don't have the facilities themselves, who haven't got running water, haven't got equipment,